Good morning, everyone. Today I am here to present Akathisia. My moderator is Ishani ma'am. Akathisia, subjective complaints of restlessness often accompanied by the observed excessive movements. Example, fidgety movements of legs rocking from foot to foot. Pacing, inability to sit or stand still, developing within a few weeks of starting or raising the dosage of medication such as neuroleptic, or after reducing the dosage of a medication used to treat the extrapyramidal symptoms. Introduction. Akathisia, from the Greek word meaning never to sit down. Akathisia is a significant and serious neurological side effects of many antipsychotic and antidepressant medications, a sensory motor disorder, and extrapyramidal. It is most often expressed as a subjective uncomfortable inner restlessness, which produces a constant compulsion to be in motion, although that activity is often not able to relieve the distress because it can be extremely upsetting to the patient. Akathisia is a common cause of non-adherence to the psychotropic treatment. Clinical presentation of akathisia. General presentation, feeling of restlessness or inner tension or discomfort with special reference to the lower limbs, an urge to constantly move the legs and sometimes other parts of the body, arms and trunks, difficulty or inability in maintaining a posture for several minutes, sitting, semi-purposeful or purposeless movements in the leg, feet, hand, arm, and or trunk, a tendency to repeatedly shift bodily position in the chair and inability to remain seated for several minutes with a tendency to get up and walk or pace. Standing on a one spot, semi-purposeful or purposeless movements in leg, feet, hand, arm, or trunk, a tendency to shift weight from foot to foot or march on the spot, an inability to stand in one spot with a tendency to walk or pace. There's a video showing how akathisia looks like. Etiology. Drug-induced akathisia, antipsychotics, more with first-generation antipsychotics, lower incidence with second-generation antipsychotics. Incidence estimated to be between 20 and 45% for patient on an antipsychotic. In a pooled analysis of 3 randomized open-label trials, the incidence of akathisia was as follows: haloperidol 57%, risperidone 20%, aripiprazole 18%, ziprasidone 17%, olanzapine 4%, quetiapine 3.5%. Lumateperone and pimavanserin are medications available only in some countries. Preliminary data suggests that lumateperone may have a low liability for akathisia and pimavanserin may ameliorate haloperidol-induced akathisia. Antidepressants like SSRIs and SNRIs. Akathisia is a Parkinsonian condition. Other drugs, azithromycin, calcium channel blockers, lithium, antidopaminergic antiemetics such as prochlorperazine and metoclopramide, dopamine depleting agents, Vesperin and tetrabenazine. Risk factors for drug-induced akathisia: drug-related, higher doses, rapid dose escalation, hypotensive agents, symptoms-related iron deficiency, cognitive dysfunction, individual-related, advanced age, female, mood disorder, preponderance of negative symptoms. Pathophysiology of akathisia. Pathophysiology of akathisia appears to be complex, involving several neurotransmitters, including dopamine, acetylcholine, GABA, norepinephrine, serotonin, and neuropeptides. The neurotransmitters most specifically linked to the akathisia are GABA and serotonin. GABA, mainly via GABA receptor interaction, exerts an influence on dopamine-dependent signaling, thus increasing or reducing locomotor activity. It involves blockade of mesocortical dopaminergic pathways. Generalized reduction in dopamine in the brain results in increased noradrenergic activity. Differential diagnosis of akathisia: agitation characterized as unintentional movements, purposeless movements; anxiety; antipsychotic-induced tardive dyskinesia, tics and tourette agitation; antipsychotic-induced dystonia; antipsychotic-induced Parkinsonian tremor; a restless leg syndrome and periodic limb movement disorder; low iron levels; alcohol or opiate withdrawal, and stimulant intoxication. Scale used for assessment of akathisia is Barnes Akathisia Rating Scale. Approach to akathisia with antipsychotics. Firstly, slow dose titration schedule or dose reduction. Secondly, select low dose antipsychotic or switching to a less potent first generation antipsychotic or second generation antipsychotic. For example, quetiapine, olanzapine, and clozapine. This should be done under close supervision to avoid exacerbation of psychosis or precipitating withdrawal symptoms, including akathisia. Clozapine for patients with chronic and persistent akathisia. Benzodiazepines are preferable to increasing the antipsychotic dose. Other treatment options and mitigation: first-line drugs, beta blockers, for example, propranolol, most commonly prescribed medication for this problem. Mechanism of action: alteration of both noradrenergic and serotonergic inputs into the dopamine system. 5-HT2 antagonist like mirtazapine 15 mg per day, trazodone 100 mg per day, niacin 15 mg per day, cyproheptadine 8 to 16 mg per day. It produces benefits comparable to propranolol with better tolerability. Second line, anticholinergic drugs, trihexyphenidyl 2 to 10 mg per day, benzotropine 1 to 8 mg per day. Third line drugs, benzodiazepines, lorazepam at 1 to 2 mg per day. In resistance cases, GABAergic agents like gabapentin 3000 mg per day, amantadine, a weak glutamate receptor antagonist and dopamine enhancing agent 100 mg per day, or clonidine, a selective alpha-2 adrenergic agonist up to 0.5 mg per day. In two randomized controlled trials, the addition of vitamin B6 1200 mg per day for 5 days significantly showed improvement. References: Comprehensive Textbook of Psychiatry, Diagnostic and Statistical Manual of Mental Disorder, and Maudsley Prescribing Guidelines in Psychiatry. Thank you.
Good morning to all. I'm going to present gabapentin and pregabalin. I'm Dr. Snigdha and my moderator is Dr. Ayushi. Gabapentin is a structural analog of inhibitory neurotransmitter GABA aminobutyric acid. GABA-1 aminomethyl cyclohexane acetic acid is a novel amino acid derived from adding a cyclohexyl group to GABA. Developed by Warner Lambert as an agent for the treatment of spasticity, first approved for use as an anti-epileptic drug by FDA in 1994 by Park and Davis. Pharmacokinetics: gabapentin is available in immediate release and sustained release formulations. Immediate release gabapentin show saturable kinetics due to saturable gastrointestinal absorption with oral bioavailability of 60% with 300 mg 3 times a day. That decreases to 30% with 1200 mg 2 times a day. Less than 3% plasma protein binding, not metabolized in liver, eliminated unchanged by renal excretion. Gabapentin clearance correlates with that of creatinine clearance. Half-lives when used as monotherapy is 6 hours. Mode of action: the primary mode of action appears to be at the auxiliary alpha-2 delta-1 subunit of the voltage-gated calcium channels, thus modulate calcium channels to reduce monoamine release. Have indirect GABAergic effects, also have anti-glutaminergic action mediated by inhibition of glutamate synthesis. Indications of gabapentin are post-herpetic neuralgia, adjunctive treatment for partial onset seizures, and restless leg syndrome. Dosage and administration: adults with epilepsy start as 300 mg a day in 3 divided dose and can be increased up to 1800 mg per day in 3 divided dose. In pediatric patient with epilepsy, start with 10 to 15 mg per kg per day, increase to 25 to 40 mg per kg per day. Post-herpetic neuralgia, the starting dose is 300 mg on day 1, can be increased to 600 mg on day 2, 900 milligram on day 3, and maximum dose can be increased up to 1800 milligram in 3 divided doses. Adverse side effects. Common side effects of gabapentin are drowsiness, weakness, dizziness, headache, tremors, blurred vision, anxiety, memory problems, nausea, vomiting, heartburns, dry mouth, constipation, increased appetite, back and joint pain. Precautions. It is classified as pregnancy category C drug as a fetal loss and teratogenicity have been demonstrated in animals. Gabapentin is classified as probably safe for lactation, though it is excreted in breast milk. Prescribed only if potential benefits outweighs the risk. Do not continue the drug abruptly. Drug interaction. As gabapentin is renally excreted, it lacks hepatic drug-to-drug interaction. Gabapentin bioavailability decreases if administered at the same time as antacids. Should be taken 2 hours after taking antacids. Pregabalin is a compound with structural similarity to the inhibitory neurotransmitter GABA that could easily cross the blood-brain barrier. Pregabalin was initially used for the treatment of neuropathic pain associated with diabetic peripheral neuropathy by FDA in 2005. Pregabalin is a S3-isobutyl GABA is a novel amino acid derived from GABA. Pharmacokinetics. Pregabalin is not bound to plasma protein, has a moderate volume of distribution of 0.5 meter per kg, half-life of 6 hours, not metabolized in liver, eliminated unchanged by renal excretion, has higher bioavailability and absorption proportional to the dose without GI saturation as seen with gabapentin. Mode of action, selective inhibitory effect on voltage-gated calcium channels containing alpha-2 delta-1 subunit, reduce depolarizing calcium influx at the nerve terminal, which decreases the release of glutamate and noradrenaline excitatory neurotransmitters. Pregabalin lack direct GABAergic actions. Indications are adjunct for treatment of adults with partial onset seizures, post-herpetic neuralgia, fibromyalgia, diabetic peripheral neuropathy, neuropathic pain associated with spinal cord injury. Dose. The dose of the pregabalin range from 150 milligram per day to 600 milligram per day. It is started as 150 milligram per day in 2 to 3 divided dose and can be increased within 1 week to 300 milligram per day in 2 to 3 divided dose. In patient with insufficient efficacy, the dose can be increased up to 600 milligrams. Adverse effects are drowsiness, dry mouth, asthenia, headache, blurred visions, peripheral edema. Precautions. Pregabalin is classified as pregnancy category C drug. It is classified as safety unknown for lactation. Increased risk of suicidality in patients with epilepsy as well as psychiatric disorders is seen. Drug interaction. Pregabalin has no hepatic metabolism, hence lack any metabolic drug interaction. Pregabalin does not yield clinically significant changes with kinetics of hormonal contraceptives. My references are Goodman and Gilman, The Pharmacological Basic of Therapeutics, and Kaplan and Sadok's Comprehensive Textbook of Psychiatry. Thank you.
Do you have any questions? You mentioned the indications of the indication from Kaplan.
So Kaplan, sir.
There is no indication of restlessness.
So there are some studies in which it can be given, but not very common.
Maybe what they use can be of knocking the dose of 100 starting to so I will not check.
pregabalin and gabapentin. The similar action. You see, this kind also acting on the same calcium channel blocker, almost same, and it can be used like indications are similar. There are other indications, mitochondria, there including GAD. Okay. Even in substance abuse, because they have a lower potential for use than benzodiazepines. So that is why they have been used in substance abuse. Okay. So fibromyalgia again, like they can clinically they can use interchangeably. Depending on the condition, get sort of pregabalin, yes. Even for insomnia,
yes, sir. So they use sometimes RLS so right. low dose भी start करें sir. Basically जो हमारे अगर हेलन पैरामीटर्स ठीक है, we prefer pregabalin over referral. क्योंकि थोड़ा सा और एजेड पेशेंट का रजिस्टर हो सकता है. क्योंकि रोकिंग सर रिबाउंड हो सकता है. रिबाउंड
drug interaction, pregabalin has this anti-epileptic. Neurological right. I heard of them, but anti-epileptic doses I have so even when they are writing for you can say indications of that. Off-label anxiety also it is you can because ultimately they are all acting on the mechanisms enhancing GABA, potentiating GABA. Everything that is having sedation that usually acts so sedating drugs, usually are like they are from the treatment. Yeah. Taking mechanism पहले साइड पे जाओ question from anyone? Moderator, I think एक moderator moderator ठीक है like somebody assisting them so you can say resource person they are helping in making the site. One can be resource person or both of you. This is we are doing this so that you also have get on the board and moderate the proceedings. Okay. Ask question. Moderator is supposed to ask question himself also and invite questions. Invite comments. You see what we are doing. So we have to do that. Okay. And chairperson will be there for the chairperson. Chairperson is the one who actually decides. Like जैसे कि मैं कर रहा हूँ कि moderator को भी वो कर सकता है. ठीक है. Anyway, you should stop. जैसे मॉडरेटर को एक ब्रीफ इंट्रोडक्शन देना चाहिए सब्जेक्ट का. Okay, 1 or 2 lines what you are going to say to the speaker, very common that we are doing it, okay, but the moderator should introduce the topic and the speaker, then she will speak over it. Okay? Then they speak. Then you can decide whether you take questions together. Then on first moderator can handle. So I hand over to Dr. Ayushi for the second session, and she can do the same, say what topic we are taking, who's going to speak. Again, together you can ask questions. Okay. You yourself can clarify because you are closer to the, like you would know better what an intern is supposed to. Okay. Our questions can be more postgraduate. So your assessment is better than what is a level of knowledge that they should have and the answers that they should be able to. Okay. MBBS level question. That we have to ask, right? And make your comments if you have any comments regarding the topic. Whatever you think you have to add it, that you have to do. All of you should participate. It is that because otherwise it is just a routine. Will come every second. Every day you come, even if 1-2 things every day you are learning, it will compound. आज क्या सीखा तुमने बताओ? आज था आज की डेट में क्या लिखा? इस दोनों प्रेजेंटेशन से क्या what one thing that you learn. Right. Very good. Very good. Very good. Okay. Ayushi, something from today's presentation. कौन से ड्रग से ज्यादा होता है किसी और स्लाइड आपकी ये पता है आप लोग फर्स्ट जनरेशन हो सकते सेकंड जनरेशन हो सकते ऐसा कुछ ओके कौन से क्लास के हमको बोलते हैं predominant dopamine blockers. And the second part is the atom sulfide. Okay, पहला कौन सा था? Okay, बड़ा बहुत curiosity जाओ, ठीक है? इस IPL देखते ना कि प्लेयर का किसकी टीम में इसका स्टैट्स क्या है, कौन सी बॉलर है, कौन सी कंट्री का है, वैसे curiosity आपको सभी जगह curiosity की कौन सा सबसे पहले है? You know which came first? बड़ा वो है बहुत पहले है वो चल रहा था कोई उसका बहुत क्या है ठीक है it came in the market and then it went away because of the pregabalin thank you right so it was then withdrawn for some time then it made a comeback with treatment indication as treatment resistance although even from our at that time of doing this, every mission was like we don't see that much of immunocytosis, which was at the time such a problem. There are many when a drug is known, there are sometimes very huge concern about one particular side effect, which was amisulpride are used sulpride with type उसका क्या हुआ? It was withdrawn. Sudden cardiac death is withdrawn amisulpride. तो diabetes में शुरू में आया तो कैटरेक्ट था कि it can cause covering of the okay ठीक है thank you both of you did well presented okay. these discussions, we are hoping to do some basic, basic level you have to brush up to know. Okay, MBBS level. What is given in KDT and say medicine के लिए basic you should cover. That they also cover basic, and you keep on repeating this thing. These are questions that for which there are some questions for which you are not given any credit in the examination. If you answer them, no credit. But if you don't answer them, then you